This is Mazen Jodi, Assistant Professor in the Baghdad Medical College. By the name of God, I would like to present this lecture in the Oncology Made Easy series, which is about the management of locally advanced breast cancer. Local advanced breast cancer and inflammatory breast cancer is a heterogeneous group of breast cancer without evidence of distant metastasis. So here the problem, there is a mass, and this mass may be fixed to the underlying structure or to the skin, and may cause inflammatory-like features in the skin, but there is no distant metastasis. And the term locally advanced breast cancer include patients which may be operable disease or inoperable disease. And the operable disease include the patient with a T3, that is the size of the mass more than 5 centimeter, with lymph node involvement, and this lymph node may be bulky tumor and fixed to the underlying tissue, or maybe inoperable locally advanced breast cancer, in which the mass is fixed to the tissue and maybe T4, and also with involvement of lymph nodes like supraclavicular lymph nodes. So also inflammatory breast cancer considered to be inoperable breast cancer. Now this picture showing the inflammatory breast cancer. Inflammatory breast cancer is a specific entity in the breast cancer. It accounts about 1 to 5% of all cases of breast cancer, and it is an aggressive variant of locally advanced disease. And it is a clinical pathological entity characterized by diffuse erythema of the skin and the presence of what is called BOD range features, like this features is seen, BOD range features, and also without, most likely without a secrete mass felt underlying the skin. And although the breast is usually diffusely thickened, maybe there is no palpable mass. It characterizes this type of breast cancer being rapid onset and initially mistaken to be infection and treated with antibiotics before the diagnosis is established. And the biological feature is different about the inflammatory breast cancer, but it's most likely to be HER2 overexpressing and high-grade disease and lacking of the hormonal receptors. The other picture here showing nipple retraction. Nipple retraction by itself is not enough feature to be locally advanced disease, because sometimes nipple retraction but the mass is mobile and the patient is fit for surgery. So nipple retraction may be associated with a mass like that is fixed mass and causing the retraction on the nipple, and this condition considered to be locally advanced breast disease and needs neoadjuvant chemotherapy. Yes. Now, the workup for patients with locally advanced breast cancer. The patient with locally advanced breast cancer and or inflammatory breast cancer should be evaluated by multidisciplinary team, ideally around the time of diagnosis. And the patient should be evaluated, of course, by starting with history and the clinical examination. History regarding the breast mass, when did the patient feel the mass, whether it is painful or not, whether it is associated with discharge, and also the physical examination regarding both the breast and also axillary region, mainly the supraclavicular lymph node examination. Many diagnostic tools for the diagnosis of local advanced breast cancer, starting from the bilateral mammography for the breast and also ultrasound as necessary. Pathology review is very important to document the diagnosis of the breast cancer, and axillary assessment, of course, by the ultrasound or other imaging necessary, and percutaneous biopsy of the suspicious nodes. Also, immunohistochemistry is very important. Of course, the ERPR receptors, in addition to the HER2 status. The MRI is optional, but it has an important role sometimes in diagnosis of inflammatory breast cancer, since the mass may be not visible by the mammography, if seen as ill-defined mass in the mammography. Also, fertility is an issue important regarding the treatment of inflammatory breast cancer or local advanced disease, because the patient may develop infertility resulted from the use of the chemotherapy. For the staging, it's very important to exclude metastasis for the disease before starting neoadjuvant chemotherapy, and this includes CT studies for the chest and the abdomen of pelvis and pelvis. The abdomen and pelvis should be with the contrast media, and MRI also of the pelvis is important, sometimes with contrast media, of course. So the imaging tests are important for diagnosis of breast cancer, as locally by ultrasound and mammography, or for the exclusion of the metastasis by use of the CT studies or MRI. This figure showing this hyperdense mass, large mass with irregular margin and fixed to the underlying tissue. This, of course, locally advanced breast cancer seen by mammography. Now, the choice of neoadjuvant treatment for the patient with locally advanced breast cancer depend on the immunohistochemistry of the disease, whether the disease showing hormonal positive or negative, whether it is HER2 positive or HER2 negative. Multiple studies and trials are done for the neoadjuvant treatment for the locally advanced breast cancer. From these studies are NASAB B18, which is the study of National Surgical Adjuvant Breast and Bowel Project. In this study, about 1,500 patients included. These patients have locally advanced breast cancer, and these patients given treatment with anthracycline and cyclophosphamide, and the results that after the use of these drugs, there were good results by decreasing the size of the mass and downstaging. The other study is NASA B27 trial. In this project, also regarding the surgical adjuvant breast and bowel project, about 1,600 patients involved in phase 3 randomized trial, and they used taxotere in addition to the use of the cyclophosphamide and the adriamycin, and they found the addition of the docetaxel to the treatment improved the disease-free survival and overall survival with operable breast cancer. The other important study is the GBAR-6 trial. In this trial done on patients with the triple negative disease, and also some people were ERPR positive HER2 ERPR negative HER2 positive patient. So the idea for this trial is on the patient with the endocrine receptor negative and HER2 negative TNBC, or some patients also involved as being HER2 positive patients. They add carboplatin in this study, and it's found the addition of carboplatin to the patient of triple negative breast cancer is effective in improvement of the progression-free survival. And also the regimen seems to increase the response in patients with triple negative breast cancer, but not in those with HER2 positive breast cancer. Okay. Endocrine therapy, as neoadjuvant endocrine therapy, is an acceptable treatment for postmenopausal women with hormonal receptor positive. Of course, these patients have hormonal positive receptor, so they use endocrine therapy as neoadjuvant chemotherapy. Although the pathological complete response rate is found to improve from 1 to 8% lower than chemotherapy. The trial involved in the study of endocrine therapy is the IMPACT trial, which is the immediate preoperative anastrozole, tamoxifen, or combined with tamoxifen. So this is the IMPACT trial. It is a multi-center double-blind randomized trial, neoadjuvant treatment for postmenopausal women with the use of anastrozole alone or tamoxifen, or combination both of anastrozole or tamoxifen. It is found there is not good results for combination of both these drugs as endocrine therapy, but they found that anastrozole is effective as tamoxifen for ER positive patients. These are postmenopausal women. So in postmenopausal woman, we can use anastrozole as neoadjuvant endocrine therapy. For patients with HER2 positive drugs, we have to add the biologic drug, which is the monoclonal antibody trastuzumab, as neoadjuvant treatment in addition to the use of the chemotherapy. And this is documented by the NeoSphere trial, when the combination of pertuzumab and trastuzumab with the docetaxel achieve highest pathological complete response rate of 39.3%. The 5-year analysis of neoadjuvant pertuzumab and trastuzumab in these patients with locally advanced breast cancer or inflammatory breast cancer and HER2 positive breast cancer suggests that neoadjuvant pertuzumab is beneficial when combined with trastuzumab and docetaxel. Now, auxiliary management for patients with locally advanced breast cancer, it depends on clinical examination and imaging test. If the patient has positive lymph node by examination or seen by the ultrasound, now FNA or two-cut biopsy is indicated to document the positivity of these lymph nodes. While if lymph nodes are not seen, and the preoperative chemotherapy is planned, now sentinel lymph node is indicated. If there is a negative lymph node involvement, no further surgery is recommended. While if there is positive lymph node seen after neoadjuvant chemotherapy, now axillary lymph node dissection is involved within the surgery of the disease. If the patient has positive lymph nodes from the start and documented by the FNA or two-cut biopsy, now after completing the neoadjuvant chemotherapy, you have to document if these lymph nodes are present or not, and if present, we have to do another pathological test. If there is negative lymph nodes, so there is no need for axillary lymph node dissection. And it is found that neoadjuvant systemic therapy has been shown to convert 40 to 75% of positive lymph nodes to negative lymph nodes. Some women with locally advanced breast cancer may be candidated for breast conservation therapy following the neoadjuvant chemotherapy. So after the completing of the neoadjuvant treatment, we have to assess the condition of the mass. In one series, local regional control following this approach appears to be excellent except in certain situations. If the patient has N2 or N3 lymph nodes, if there is lymphovascular invasion, if there is residual primary pathological size of more than 2 cm, or if there is multifocal residual disease, in this condition, mastectomy is indicated. Otherwise, if the mass become downstaged and the mass become mobile and there is complete pathological response, here in this condition, when there is complete response or partial response but lumpectomy is possible, the lumpectomy is indicated. In condition, of course, where there is partial response but lumpectomy not possible or confirmed progression of the disease, now mastectomy is indicated with axillary lymph node dissection. The radiotherapy most likely is indicated for patient after the completing of the neoadjuvant chemotherapy and after the surgery. And of course, lymph node involvement is very important. If there is involvement of lymph node, we have to give radiotherapy. In most conditions, radiotherapy is indicated. This slide showing the assessment of response to treatment. If there is progression of the disease at any time or partial response, as I mentioned, lumpectomy not possible, and here mastectomy is indicated. While if there is partial response and lumpectomy is possible, or there is complete pathological response, here of course the role of lumpectomy, that's to say breast conservation therapy. The preoperative systemic therapy for inoperable disease after the completing of the neoadjuvant chemotherapy and find the response. If there is good response, mastectomy and surgical axillary staging with or without reconstruction, or lumpectomy with surgical axillary staging if there is response to this treatment, while if there is no response, consider additional systemic chemotherapy or radiation therapy. That is meaning after completing of neoadjuvant treatment, we assess the patient. If there is good response and surgically indicated, we do surgery. Otherwise, if there is no good response, we can add further systemic therapy or we can use also preoperative radiotherapy, which is very rarely to be used in the treatment of the and management of the breast cancer. Usually the radiotherapy given post-op, but in this point, in the neoadjuvant treatment of locally advanced breast cancer and there is no good response to the treatment, we can add radiotherapy before starting surgery. And we see after the addition of the radiotherapy and systemic therapy, if there is response, the treatment will be surgery as above, or if there is no response, now there will be individualized treatment accordingly. Now, this is slide showing the drugs that are used for the treatment of neoadjuvant chemotherapy. The preferred regime is the use combination of doxorubicin and cyclophosphamide followed by paclitaxel, which is Taxol, and this is in form of dose dense, that's to say every 2 weeks rather than 3 weeks. The other preferred protocol is the use of AC, which is adriamycin cyclophosphamide, followed by weekly use of paclitaxel. There is other preferred regimen, which is use of combination of docetaxel with cyclophosphamide, or in triple negative cancer, the addition of carboplatin. Other recommendation regimen is the use of weekly Taxol with carboplatin or docetaxel with carboplatin, especially for the patient with triple negative breast cancer, these which are the TNBC, triple negative breast cancer. Now this figure from NCCN also showing the preoperative regimen and the preferred regimen for the condition of HER2 positive disease. Of course, when there is HER2 positive condition, we have to add the biologic drug, which is the trastuzumab, as AC followed by taxane plus trastuzumab. So we completed the AC protocol and then followed by the use of Taxol or Taxotere with the use of trastuzumab. The preferred drug is the use, of course, the paclitaxel plus the trastuzumab with various schedules. Another preferred regimen is the use of AC followed by T plus trastuzumab plus pertuzumab, so combination of the trastuzumab with pertuzumab. Other preferred protocol is combination of Taxol and trastuzumab from the start, or the use of TCH protocol, which include the docetaxel, carboplatin, and trastuzumab. There is a point here: if the residual disease after preoperative therapy, now the trastuzumab emtansine can be used as category 1 alone. And if trastuzumab emtansine discontinued for toxicity, then trastuzumab is used category 1 plus minus pertuzumab to complete 1 year of therapy. So this regimen can be used in condition of HER2 positive locally advanced breast cancer. Now we gave the patient neoadjuvant treatment and we did surgery for the patient. We have to complete the adjuvant treatment for this patient. And the adjuvant treatment includes completing the planned chemotherapy regimen course if not completed preoperatively. That's to say, if the patient received, for example, 4 cycles of AC, adriamycin, and cyclophosphamide, and the patient did surgery, whether breast conservation therapy or mastectomy, you have to complete the further 4 cycles of taxane. And also, we have to use adjuvant radiation therapy, which is preferred to be given for patient after surgery of local advanced breast cancer. And if the patient, of course, endocrine receptor positive, we have to give adjuvant endocrine therapy according to the age of the patient and condition of the patient. If HER2 positive, here it's very important point, complete up to 1 year of HER2 positive targeted therapy with trastuzumab category 1 plus minus pertuzumab. And of course, HER2 targeted therapy need follow up by echocardiography for cardiac function, as trastuzumab is cardiotoxic drug with irreversible cardiotoxicity. HER2 targeted therapy may be administered concurrently with radiation therapy and with endocrine therapy if indicated. For example, in patients with triple positive breast cancer. Now, I want you to share your opinion regarding this case as assignment in this lecture. A 52 years old female presented with right breast mass, and this mass about 4 by 5 centimeter in size, fixed and hard inconsistency associated with right axillary lymphadenopathy. That's to say, this patient has local advanced breast cancer, and TrueCut biopsy shows invasive ductal carcinoma, with immunohistochemistry being a triple positive breast cancer. Now, the first question, what is the next step? What is the thing we have to do it before starting the treatment? And the second thing, if the patient needs neoadjuvant treatment, what is the best choice of a drug, and depending on which evidence, that's to say, in which trial and which study for the use of these drugs. Thank you.